Well, now I have the pleasure of introducing our keynote speaker. You know, in 2009, I was coming back to my hotel after attending a national meeting, and I saw Dr. Joe Buyske and Steve Schweitzberg sitting at the bar, and they seemed a bit in cahoots about something. And when they saw me, they called me over, and Dr. Buyske asked me if I'd be willing to be the program chair for her annual meeting when she was SAGE's president. To be honest, up to that point, I wasn't sure that she had even noticed me in the work in SAGE's, so I was extremely honored and jumped at the opportunity, especially coming from someone from whom I had such immense respect and admiration. Years later, while attending another meeting, I received a voicemail on my phone from Dr. Buyske, and it seemed rather urgent. And I was concerned, so I called her back right away. And she told me she had called to tell me that she had asked to be the first person to deliver the news that I had been chosen to be president of this organization. I was speechless. Over the years, I've had the privilege of working with Dr. Buyske not only within SAGE's, but also within the American Board of Surgery, where she has been instrumental in guiding that organization to new heights in surgical training and certification. She has an amazing clarity of thought, is calm amidst chaos, and has vision to what needs to be accomplished and the patience to do the work required to overcome difficult obstacles. SAGE's has 2 named lecturers as part of its annual meeting, and the president has the honor of choosing who speaks in these prestigious spots on the program. In choosing the speaker for our Marks lecture, I could think of no one better to help us rediscover our passion for surgery while showing us the way forward and how we're going to make our profession better. Dr. Buyske is the Associate Executive Director of the American Board of Surgery and the Director of Evaluation. She is past president of SAGE's and remains active on several committees. In fact, her dedication to providing surgical care in places like Haiti have fostered her SAGE's presidential initiative of forming the Humanitarian Committee, which provides amazing community service, including to the communities where our annual meeting is held. Dr. Buyske's clinical career is in minimally invasive foregut surgery, and she currently serves as the adjunct professor at the University of Pennsylvania School of Medicine, where she does clinical work and teaching on the emergency surgical services. Her passions include training surgeons, taking care of patients, working to provide equitable global access to surgery, running, fresh local food, always let her choose the restaurant, and being with friends and family. So please join me in warmly welcoming to the podium our SAGE's past president and the 2016 Gerald Marks Lecturer, Dr. Joe Buyske.
Well, thank you, Dr. Duncan, mostly for your superb leadership of our society and for your friendship, and also for that very kind introduction. Thank you to SAGE's for giving me the honor of the stage, and your great company over the years as well. And thank you especially to Dr. Marks for your vision, your wisdom, persistence, and foresight in fathering SAGE's. I also want to thank you, Dr. Marks, for your kindness in mentoring a young surgeon in Philadelphia all those years ago. I'm honored by being invited to give the lecture that bears your name. I want to talk today about our lives as surgeons, about the entrustment and the responsibility that comes with choosing that life, and the duty that comes along with being given the opportunity to become a surgeon. I'll do that in 3 parts. First, I want to talk about surgical training in this country, using that as the unifying thread, or suture, if you will. I also want to talk about surgical leadership. And last, I want to talk about our role as global citizens. I'll start by talking about training.
Look around, how lucky we are to be alive right now. Look around, how lucky we are to be alive right now. History is happening in Manhattan, and we just happen to be in the greatest city in the world, in the greatest city in the world.
How lucky we are to be alive right now. We turn out excellent, skilled, competent surgeons every year, almost 1,000 of them, year after year. They know more than we did. They've done more across the arena of patient care than we could have dreamed of. It's true that their confidence level may have changed from that of a finishing generation of residents a few years ago. It's also true that the criticism by their elders has not changed. My senior residents criticize me. Those changes have changed for probably 50 years, maybe even 2,000 years, as evidenced by this quote, often attributed but completely untraceable to Socrates, certainly used by the mayor of Amsterdam 50 years ago. The residents now love luxury. They have bad manners, contempt for authority. They show disrespect for their elders, and they love chatter in place of exercise. Residents are tyrants, not the servants of their attendants. They no longer rise when elders enter the room. They contradict their attendings, chatter before company, gobble up dainties at the table, cross their legs, and tyrannize their teachers, or something like that. Regardless of whom we credit, we know that the older generation always judges the younger one harshly, and has done so for thousands of years. So our concerns about training must be tempered by remembering that. If opinions are subjective, though, what do we know to be facts? Well, one fact is that work hours have changed. At last year's Marx lecture, Dr. Frank Lewis pointed out that with the advent of the 80-hour work week, we lost what is the equivalent of an entire year of training without making any kind of a compensation for that. The reduction to 80 hours from 100 hours, which was probably a conservative estimate, results in a net loss of 4,800 hours, or 48 100-hour work weeks. I would counter that by invoking memories of what I did with some of that extra time when I was a resident at the hospital across town. I stood in line at the printer in the lab to print copies of the lab reports for our patients. I stood at the window in the radiology room and waited with a list of the x-rays that I needed to bring to afternoon rounds. I put in central lines. At one hospital at midnight, I moved beds from the men's wards to the women's wards or back again, depending on the maldistribution of beds according to need. I found available telephones, which were fixed to desks and walls, and I made telephone calls. And I was stuck waiting there until they called me back. Sometimes I had to call over and over again when I got a busy signal. I drew blood, and I drew a lot of it. Now residents get labs on their smartphones while they're walking down the hall or waiting for an elevator or in the midst of rounds. We can see x-rays at every computer. I don't think any residents are moving beds. Pages and phone calls and waiting for calls back are now text. They're instantly sent, they're instantly received. Blood drawing teams, radiology, nursing, all have taken over central lines, both their placement and their care. Operations are shorter. A Whipple in 1990 took 5 hours, 7 hours. Now it takes 3 to 4. Staples, ligature, wound vacs, CUSA, topical hemostatics, they all save time. Financial pressures on hospitals have made OR time a premium, and OR turnover time is shortened. We can fill in more operations on a given operating day than we've ever been able to before. I'm not sure that we've really lost all that much time that was spent learning the skills, the art, the craft of surgery. So do we need to recruit time? I'm not sure. I do think we need to recruit some of this flexibility in time spent, and that we have to respect the responsibility and the autonomy of our adult trainees' ability to decide when they need to stay in the hospital and when they can go home. To that end, the results of the first trial were published in the New England Journal in February. 117 U.S. training programs were randomized to flexible work hours versus the standard ACGME mandated work hours, while staying within the 8-hour limit. We learned that the patients have the same outcomes. The residents feel better about their work. Not surprising that a group of adults who have committed themselves to a lifetime of caring for patients would feel that way. The ACGME is hosting a retreat on duty hours this week and has solicited opinions from all the major surgical groups. The results of this paper was presented, among others, and I'm optimistic that more flexibility in work hours, both at the level of junior residents and the critically important transitional chief and fellowship years, will be considered. 8 hours a week is plenty of time to train a surgeon. The question is, how do we make the best use of that time? If we don't need to recoup actual hours, what should we be doing with the time that we have? It's incumbent upon us to be always alert to the opportunities to make training better. Many of the changes of residency have been reactive to the pressures of service and billing. Key among those changes have been shortened rotations, in which the apprenticeship model has been quietly diminished to the point of elimination. Many of us spent 2 or 3 or 6 months with one main surgeon, getting to know them, their diagnostic and therapeutic approach, their rounding style, the exact instruments, their quirks around how to tie in a drain, when to remove it. Was that better than the short rotations we have now, where teams of residents that change from morning to night work with teams of attendings, one day with one day with another? I don't actually know. I do know that it changed, and we didn't account for the effect of those changes with any kind of thoughtful or proactive responsive. What was lost when that old system drifted away, almost without our noticing it? The development of relationships and trust, and with that, entrustment. Almost certainly an intensity of mentorship, increased sense of confidence that having a good mentor brings. Is it possible that this is part of what's driven the move into fellowships, where 1 or 2 fellows each year work with a small number of attending surgeons day in, day out for 1 or 2 years, recapitulating the older, longer rotations of residency? I think so. I think the need for that kind of close teaching and relationship is part of what drives 80% of our trainees into fellowships, both ACGME accredited and not. There's another fact. Look around. Residents want to focus earlier. We need to open our eyes to what's happening around us. We know that residents like to work on the skills they're going to use later while they're in a protected and mentored environment. When the chief resident on the service is allowed to assign residents to cases, they themselves pick the cases that match their career goals. Despite years of RRC and ABS attempts to make all training equivalent, in the end, residents going into breast surgery will finish their residency with more breast operations, and those going into GI surgery will finish their residency with more Nissens. We also know that residents aren't deterred by training for long periods of time, since the added length of training doesn't seem to be dissuading them from going into fellowships. We know, too, from multiple studies, that they feel insecure when they step out of training into the world, and we feel insecure about them. So where can we go with these facts? We can let the residents train a little longer and focus earlier on their career interests. We're already doing both of those things in a somewhat organic manner. It is already happening. Residents almost all now train longer by adding on fellowships. They vote with their feet by selecting cases in their field of interest. When allowed, either as part of the ABS flexibility and training pathway or the consortium study FIST, they select up to 12 months of elective time in their last 3 years of training towards their career goals. We can push these things further. We can make the decision trees clearer. We can move portions of fellowship training into residency training in an organized and structured manner. Many of you know that progress towards a goal of core plus training in surgery has been afoot for years, since the Blue Ribbon Committee report in 2005. A lot of progress has been made towards those goals, with a much broader understanding of what that would look like, and a slow recruitment of consensus.
I know that we can win. I know that greatness lies in you. But remember, from here on in, history has its eyes on you. History has its eyes on you.
The American Board of Surgery released a statement on residency redesign, committing to core plus training. The American Surgical Association wrote a letter to the ABS to support it. As always, progress is 2 steps forward, then a step back. SAGES is a forward-thinking society, with members self-selected as people who see opportunity where other people see obstacles. And SAGES members and leadership have been key to the progress that's been made and remains to be made. A recent push towards recognizing fellowships that fall outside the usual ABS and RRC parameters didn't quite make it over the hill.
You don't have the votes.
You don't have the votes. You're gonna need congressional approval, and you don't have the votes.
You don't have the votes. But this is okay. It's common to be expected with big change and allows for fine-tuning and ultimately for a better end product. A current creative example of this is happening right now. History is happening right now in the arena of transplant surgery. Transplant fellowships are not overseen by the RRC and the ABS, but rather by the transplant societies themselves. This allows them greater flexibility in decision-making and in standard setting. This year, for the first time, they shortened the duration of training for one of their budding transplant surgeons by using the ABS flexibility and training pathway. The resident used flexible rotations to do 12 months of transplant surgery in the last 2 years of his training, simultaneously meeting all the ABS requirements and making him eligible for board certification. He then moved into his transplant fellowship at the same institution with the first 12 months under his belt under the oversight of his mentors. Now he's doing the next 12 months and he'll be qualified as a transplant surgeon, having shortened his training by a year and having met all requirements of both worlds. We already have this phenomenon, early specialization, or ESP, in vascular and cardiothoracic surgery, both ABMS recognized specialty. The world is your oyster for being creative in this way if you're in the field of an independent society-sponsored fellowship, like minimally invasive surgery, like SAGES.
I am not throwing away my shot. I am not throwing away my shot. Hey, yo, I'm just like my country. I'm young, scrappy, and hungry, and I'm not throwing away my shot.
This slide was lent to me by the ever-creative Eric Holmboe of the ACGME. This and the following too. In the diffusion of innovation theory, SAGES would be on the left side of the slide in the category of innovators and early adopters. It'll be part of the work of our society to convince the pragmatists, the conservatives, the skeptics about the necessity and appropriateness of change. We know how to do this. The core of our society, endoscopy, and then minimally invasive surgery, was based on this facet of SAGE's personality, of recognizing the opportunity for change in the face of other skepticism. We look around, we see change is needed, and we know how to manage it. So if we can support core plus training, and residents are willing to train for longer, and we can facilitate earlier focus on areas of interest, what else remains? Well, there is the confidence issue. Finishing residents don't trust themselves. Their supervisors don't necessarily trust them to function independently. This is where we have to use our opportunities and tools to make things better. One opportunity is in the area of EPAs, or entrustable professional activities. EPAs were developed in the Netherlands. They're in use in medical training there, also in Canada, and in some fields such as pediatrics and neurosurgery here in the US. What is an EPA? It's a tool of training and assessment. A single EPA is a unit of professional practice, a task, a skill, maybe an operation, or a responsibility that through training and assessment can be entrusted to an unsupervised trainee. If it sounds a little bit too much like a new fashion in education, consider this fact. We're already using EPAs. When you entrust a resident to see the patient in the emergency room before you do, that is an EPA. When you entrust a resident to put in a central line or a chest tube, that is an EPA. When you entrust a resident to position the patient on the operating room table for your case, or to start an operation, or to close, or to take another resident through a simple procedure, those are all EPAs. When we can provide a rich roster of things that we trust residents to do unsupervised, deliberately, and proactively, they can know that we trust them, and we can trust them themselves. Providing such a portfolio of confidence is our obligation as teachers and mentors. The identification and sequencing of EPAs of increasing difficulty, of increasing risk, of increasing sophistication should be the backbone for surgical training. At the point that we can fold all these things together, entrustment, longer training, earlier focus, and clearer identification of processes, we will have the training process our residents deserve. We owe them that. The world looks to the US to partner in leadership in surgery. We're one of the richest nations in the world. Our physicians are paid more than almost anywhere else. Our standard of living is among the highest. We can afford to pause and consider. We have the time and the liberty to participate globally in the ideal development of standards of training and patient care, and to share it with our colleagues all over the world. Disparities in healthcare come from lack of access, lack of infrastructure, suboptimal training, or lack of access to training. We can have an effect on these issues, both small and large, and we must.
Rise up when you're living on your knees, you rise up. Tell your brother that he's gotta rise up. Tell your sister that she's gotta rise up.
When are these colonies gonna rise up? 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 Rise up.
Rise up. Rise up as surgeons. Rise up as SAGES. As airplanes have gotten faster, as the world's gotten richer, as the internet's grown and communications have become easier, our ability to communicate around the world has exceeded our wildest dreams. Surgeons work together, and they're involved everywhere. In our broad community, the American College of Surgeons has members from 135 countries, teaches ATLS in 65 different countries in multiple different languages. That program is only continuing to grow. The ABS collaborates with close to 20 countries in resident assessment and training. SAGE's own global activities include formal courses in 9 different countries, and many more are reached by SAGE's members teaching ATLS or teaching FLS, offering lectures and symposia, volunteering. As surgeons, we're committed to the care of our patients. It's our highest calling. We embrace the concept that all patients are the same and deserve access to safe care. As we work to make resident training in the U.S. the best it can be, so we work with our colleagues all over the world to develop locally appropriate surgical education and practice, to increase access to care, and to make that care safe for all of us. One of the hallmarks of SAGES is that it develops leaders. I'm often asked the question, how can I get involved? I want to have an impact. Often the question is more specific. How can I get to be on the board of SAGES? How can I get to be a director of the ABS and have a say in all those issues? The answer is right here in this room. Through SAGES, I'll use my own story as an example because I like to take some of the mystery out of the process because for sure, if I can do it, you can do it too. In 1993, my first job out of residency was at the Leahy Clinic, a little bit north of here. The Leahy was ahead of the curve on managing and standardizing faculty resources. We were allotted $1,000 for subscriptions, dues, and membership. As I tried to figure out how to best manage that small pile of cash, my chair, Ricardo Rossi, said, I think you should join this little society called SAGES. I think they have it right. I think that in the future, that will be the place to be. So I joined that little society, and I went to my first meeting in Orlando. And at that first meeting, I was assigned to the now defunct Public Information Committee, and that was my shot. Being diligent and responsible young women, I did everything that was asked of me. I even imagined assignments that hadn't been made yet and did them. And eventually I chaired that committee, which allowed me to participate at SAGES board meetings. Then I was elected to the SAGES board. I went to every committee meeting on time. I stayed to the end, and the same with the board meetings. And from there, I was nominated by SAGES to the American Board of Surgery and elected by them as a director. Later still, through that experience, I became part of the executive leadership at the ABS, and that gives me a voice on all of these topics. This is my shot. I hope the short story helps demystify some of the process. If it can happen to me, it can happen to you. Look around. Be ready. Do not give away your shot. SAGES leaders sit in all the leadership chairs of American surgery. They're at the American Board of Surgery, on multiple committees and councils. They sit at the college, at the ASA, and they drive the boat of the most productive and forward-thinking society of them all, SAGES. We can take on these changes. In closing, I just want to tie it together. Look around you, how lucky we are to be alive right now. We are well-trained. We are training good surgeons. Training is about providing the best care to our patients. Global work is about providing access and care to people one by one or system by system. Rise up, attend to those needs. Leadership, which we can learn through SAGES, is getting to the work of figuring out how to take the best care of patients around the world through training and ongoing education, both of ourselves and of others. When we can combine our experience in training surgeons with our commitment to leadership and excellence, when we engage with both the needs of our colleagues and patients around the world, we work together as SAGES and as surgeons, and we will have done the work of tying it all together. Thank you very much.
Rise up, here he comes. Here comes the general. Ladies and gentlemen. Here comes
Get to stop for 1 second. I have one more thing.
Rise up, here he comes. Here comes the general. Ladies and gentlemen. Here comes the general. The moment you've been waiting for.
That was perfect. I knew that Joe would be able to mix vision with enthusiasm and motivate us. So in gratitude for your willingness to do this lecture, and I have a plaque for you. It says SAGES 2016 Gerald Marks Lecture, presented to Dr. Joe Buyske. Thank you. That was perfect. That was perfect. Enjoy the rest of the meeting.